Welcome to the Digital Preceptor. How is it that we can completely cure a virus that constantly mutates and has no vaccine, yet we can only temporarily suppress a virus that we've had a highly effective vaccine for since 1982?
It is a massive paradox, honestly. But pull up a chair, grab your notebook, and let's get to work on that.
Yeah, exactly. Today, we're taking on the role of your academic tutors.
Right.
So if you are a medical student preparing for your board exams, you are definitely in the right place.
For sure. Our focus for this session is a really high-yield, conceptually driven review of acute and chronic liver inflammation.
Yes, the heavy hitters.
Exactly. We're targeting the major testable areas, so viral hepatitis, drug-induced liver injury, and, autoimmune hepatitis.
And we won't just be like throwing endless lists of symptoms at you. I mean, memorizing algorithms only gets you so far on the wards, right?
Oh, totally. Or on a really difficult board question.
Yeah. So we are going to unpack the pathophysiology, like the actual mechanisms behind the diagnostic criteria.
And the pharmacology of the modern treatments, which has changed so much. Because if you understand the underlying mechanism, why a specific marker disappears from the blood, for instance.
Or how a virus actually enters a cell.
Right, exactly. Then the clinical presentation just becomes completely intuitive.
It really does. Well, let's start by looking at what I call the enteric twins, so hepatitis A and hepatitis E.
Ah, the fecal oral viruses.
Yeah, exactly. And you could anchor this for your exams with a really simple trick. So A and E are the ones transmitted enterically.
That's a great mnemonic.
Think A for apples and E for eating, enteric.
I love that. So from a structural standpoint, hepatitis A, or HAV, is a positive sense RNA picornavirus.
Okay, picornavirus.
Yeah, and the mechanism behind its fecal oral transmission is, it's completely tied to its physical structure.
Right, because it's non-enveloped, yeah.
Exactly. It is a non-enveloped virus. I mean, many viruses have a lipid bilayer envelope, but lipid bilayers are super fragile.
They get destroyed by stomach acid, right?
Stomach acid and, the detergent action of bile salts in the intestines.
Right, bile basically acts like soap.
Exactly like soap.
Now,
but because HAV lacks that envelope and only has this really tough protein capsid, it's highly resistant to heat, to acid, and ether.
So it just easily survives the whole gauntlet of the GI tract to get to the liver.
It breezes right through.
And once it gets to the liver, the incubation period is roughly, 3 to 4 weeks?
Yeah, right around there.
And a really high yield point to remember here is that HAV replication is strictly limited to the hepatocytes.
But the virus itself isn't what's destroying them.
Right. The virus is not directly cytopathic. I mean, it isn't just blowing up the liver cells from the inside.
No, the injury is actually entirely immune-mediated.
Which is wild to think about.
It really is. The liver necrosis and that massive spike in aminotransferases you see on the labs, that's all collateral damage.
Friendly fire, basically.
Exactly. The host's own CD8-positive cytolytic T cells, they recognize the viral antigens displayed on the surface of the infected cells.
And then they just initiate apoptosis to clear the infection.
Right, so the immune system is essentially destroying its own tissue to eradicate the intruder.
Wow. So clinically, when a patient presents with jaundice, right upper quadrant pain, and an aversion to smoking.
Oh, yeah, the classic board clue.
Right. It's bizarre,
right,
but it shows up all the time for acute hepatitis.
Yeah.
So the diagnosis really comes down to specific antibodies.
We look for IgM anti-HAV for an acute infection.
And the mnemonic here for you guys is simple. M means miserable right now, and G means gone and immune.
That is perfect, because IgM is your acute phase reactant, right?
Yeah, exactly.
While IgG anti-HBc persists indefinitely, so that gives you lifelong immunity.
Okay, so let's compare that to hepatitis E then.
Right, HEV. So like HAV, it's an enterically transmitted RNA virus.
But it's in a different family, right?
Yeah, entirely different. It belongs to a viral family called orthohepavirus.
Okay.
Epidemiologically, genotypes 1 and 2 are endemic in developing nations, and they're responsible for these massive waterborne outbreaks.
Right. And there's a critical, heavily tested clinical pearl for HEV regarding pregnant women.
Oh, absolutely. In the third trimester, HEV infection carries an alarmingly high mortality rate.
It's up to 20%, isn't it?
Yes, often due to fulminant hepatic failure. It's incredibly dangerous.
Wow. But then genotypes 3 and 4 present a totally different scenario.
Yeah, they're zoonotic.
Meaning they jump from animal reservoirs like swine or deer.
Right, and those are actually endemic in the United States and Europe.
Okay, so question. Because HAV and HEV act so similarly clinically, I mean, they're both fecal-oral, both RNA viruses, both generally cause acute self-limiting disease.
Right.
Is it safe to assume they share some kind of evolutionary ancestor?
No, they absolutely do not. And test makers love to exploit that exact assumption.
Ah, classic trap.
Total trap. They share zero genomic homology. It's actually a classic example of convergent evolution.
Meaning they cause similar clinical syndromes despite being totally genetically unrelated.
Exactly. Okay, so moving from the gut to the bloodstream.
Oh boy, here we go.
Yeah, we enter the territory of the heavyweights, hepatitis B, C, and D.
The blood-borne viruses. And these are the primary drivers of chronic liver disease, cirrhosis, and, hepatocellular carcinoma.
Right, and hepatitis B is just the ultimate outlier in this whole group.
Oh, for sure. So hepatitis B virus, or HBV, is the only DNA virus among all the major hepatitis.
Yep, it belongs to the hepatovirus family. And it possesses this remarkably compact 3,200 base pair circular genome.
Which is partially double-stranded, right?
Exactly.
I always think of the HBV genome as this masterpiece of evolutionary compression. I like to picture it as a tightly packed zip file.
Oh, that's a great way to look at it.
Because it contains only 4 overlapping genes, S, C, P, and X.
And it uses that mechanism called overlapping reading frames.
Right. So imagine reading a sentence. But if you start reading from the second letter instead of the first, it spells out an entirely different message.
It's brilliant. By just shifting the translation start site, this tiny genome creates the surface antigen, the core antigen, the polymerase.
And the X protein.
Yes, the X protein, which is an oncoprotein known to transactivate host genes and basically drive liver cancer.
Okay, so that structural efficiency is matched by a really unique replication mechanism, right?
Totally. Because even though HBV is a DNA virus, it replicates via reverse transcription.
Wait, reverse transcription? Like HIV?
Similar concept, yeah. Once the viral DNA enters the hepatocyte nucleus, it forms covalently closed circular DNA, or cccDNA.
Okay.
Then this is transcribed into a pregenomic RNA intermediate.
Ah, so it goes from DNA to RNA.
Right. Then the viral polymerase uses its reverse transcriptase function to turn that RNA back into the DNA that actually gets packaged into the new viral particles.
A DNA virus using an RNA intermediate, that is incredibly testable.
Oh, 100%. It's on every board exam.
All right, well, let's untangle the serology then. Specifically, I want to talk about the window period, which is just notoriously confusing.
It really is.
Because it always felt biologically contradictory to me. Like, the surface antigen just vanishes before the protective surface antibody even appears.
Yeah, it seems like magic, but the physical logic behind the window period just comes down to immune precipitation.
Okay, walk us through that.
So during the acute phase, the patient produces a massive amount of hepatitis B surface antigen, or HBsAg.
Right, the viral load is peaking.
Right. And as the immune system finally mounts a response, it starts churning out anti-HBs antibodies.
And these antibodies bind directly to those circulating surface antigens.
Exactly, forming these really large immune complexes.
So they are basically locked together in this microscopic embrace in the blood.
That is exactly the case. And standard laboratory assays are designed to detect free unbound antigen or free unbound antibody.
Oh, because they are locked together in these complexes and getting rapidly cleared from circulation.
Neither the free antigen nor the free antibody reaches the threshold of detection.
They essentially just cancel each other out on the lab readout.
Exactly. So in that invisible gap, the only positive marker you will find to prove the patient has an acute infection is IgM anti-HBc.
The core antibody.
Yep, because the core antigen stays inside the hepatocyte, right?
Right, so it doesn't circulate freely to bind up the core antibodies.
Exactly, leaving those core antibodies easily detectable in the serum.
Okay, quiz time. Let's say we're tracking a patient. We also need to monitor the E antigen, right? HBag.
Yes, definitely. That's a soluble protein secreted during active viral replication.
So when HBag is positive, it indicates high viral replication and high infectivity.
Spot on. And if HBsAg persists in the blood for greater than 6 months, well, then the patient has officially transitioned to chronic hepatitis B.
Which brings us to the treatment criteria. Because we cannot reliably cure HBV, can we?
Sadly, no. Because that cccDNA we talked about, it hides deep inside the host nucleus, acting as a permanent template.
So the goal is really just long-term suppression.
Right. And the World Health Organization is super clear that we do not treat every single HBV carrier.
So who do we treat?
We initiate treatment if there is clinical evidence of cirrhosis or if non-invasive markers indicate significant fibrosis.
Like an APRI score greater than 0.5.
Exactly.
Wait, let's actually unpack the APRI score for a second. The AST to platelet ratio index.
Oh, we definitely should.
Because it's a genius piece of physiological reasoning.
Mm-hmm.
So, as the liver gets damaged, AST leaks out of the hepatocytes, driving the top number up.
Right, and simultaneously, a fibrotic liver loses its ability to synthesize thrombopoietin.
The hormone that stimulates platelet production.
Exactly. Plus, portal hypertension causes the spleen to enlarge, which sequesters circulating platelets.
So the platelets drop. High AST divided by low platelets gives you a high APRI score.
Which gives you a highly accurate window into liver scarring, completely without needing a biopsy.
It's so elegant. So if the patient meets those criteria, or if they have a high viral load.
So an HBV DNA greater than 2,000 international units per milliliter.
Right. Alongside elevated liver enzymes, what do we use?
We use first-line oral nucleoside or nucleotide analogs that have really high resistance barriers.
Specifically, tenofovir or entecavir.
Exactly.
And we should definitely touch on vertical transmission here.
Oh, huge board topic.
Right. So if a pregnant patient has chronic HBV and an extremely high viral load.
Specifically, an HBV DNA greater than 200,000 international units per milliliter.
Okay, so she receives maternal tenofovir prophylaxis in her 3rd trimester.
Yes. This suppresses the viral load to protect the infant during delivery.
And then immediately after birth, the infant receives the hepatitis B vaccine and hepatitis B immune globulin to basically intercept any viral particles that crossed over.
Spot on. Now, before we leave the HBV ecosystem entirely, we really must factor in hepatitis D or HDV.
The defective virus.
Yes. HDV is a defective, single-stranded RNA virus. It's basically an obligate parasite of hepatitis B.
Because it lacks the genetic machinery to create its own envelope, right?
Exactly. So it completely hijacks the HBV surface antigen coat to package its own genome and infect other cells.
Clinically, you absolutely must distinguish between co-infection and superinfection here.
Yes. Co-infection happens when a patient is exposed to both HBV and HDV at the exact same time.
And the immune system usually clears both, right? Because the HBV factory hasn't been established yet.
Exactly right. Superinfection, though, that is the really dangerous scenario.
What happens there?
In a superinfection, HDV infects a patient who is already a chronic HBV carrier.
Oh, wow. So the host's liver is already mass-producing the HBV surface antigen.
Yep. So HDV has an unlimited supply of viral coats.
So it just replicates explosively.
Exactly, which leads to a much higher risk of fulminant liver failure and super rapid progression to cirrhosis.
Terrifying. Well, let's transition to a virus where the medical narrative has actually completely flipped in the last 10 years. Hepatitis C.
Oh, this is such a great success story. We've gone from managing this chronic debilitating disease with harsh interferons to routinely curing it in weeks.
It's incredible. So hepatitis C virus, or HCV, is a positive sense RNA virus in the hepatovirus genus.
Right. And unlike HBV, which enters the nucleus, HCV replicates entirely in the cytoplasm.
And it translates its genetic material into one massive 3,000 amino acid polyprotein, right?
Yes, this giant non-functional protein. It has to be meticulously sliced into functional pieces by proteases.
Host proteases and the virus's own proteases like NS2 and NS34A.
Exactly.
But wait, despite understanding its machinery so well, why don't we have a vaccine for hepatitis C? I mean, we have one for B.
It comes down to the viral RNA polymerase. It totally lacks proofreading ability.
So it's just making constant transcription errors.
Exactly. And this leads to extreme genetic diversity, specifically in a sequence called the hypervariable region of its envelope proteins.
So within a single patient, the virus mutates so rapidly that it exists as this swarm of closely related variants.
Right. They call them quasi-species.
Quasi-species. Wow.
By the time the host's immune system designs neutralizing antibodies against one envelope structure, the virus has already mutated into a totally new shape.
So this constant evasion makes designing a universal or even stable vaccine nearly impossible.
Exactly. And because it hides so well, diagnosis relies on a reflex testing algorithm.
Right. So you start with an anti-HCV antibody rapid test.
But a positive antibody only proves past exposure, you know?
Right, because up to a quarter of patients actually spontaneously clear the virus.
Exactly. So if the antibody is positive, the lab reflexively runs an HCV RNA test to quantify the active viral load.
And if the RNA is positive, we treat.
We treat with direct-acting antivirals, or DAAs.
The game changers.
Total game changers. These drugs are basically molecular scissors that specifically target the non-structural proteins of the virus.
And pangenotypic fixed-dose combinations are the standard of care now.
Right, so like sofosbuvir combined with velpatasvir for 12 weeks, or glecaprevir combined with pibrentasvir for 8 weeks.
And these regimens achieve a sustained virologic response, which equates to a complete virologic cure in over 95% of patients.
It's truly miraculous.
But wait, I have to interject with a vital super high-yield board warning here.
Go for it.
Do not give protease inhibitors to patients with decompensated cirrhosis.
Yes, so crucial. The DAAs ending in the suffix previr, like glecaprevir, are strictly contraindicated there.
And the mechanism is really straightforward, right? These specific drugs are heavily metabolized by the liver.
Right. And in decompensated cirrhosis, the liver's metabolic pathways have just completely failed.
So if you administer a protease inhibitor, the liver cannot clear it.
Which leads to massive drug accumulation in the plasma and potentially fatal, toxic, drug-induced liver injury.
So you have to use alternative regimens, like the sofosbuvir, velpatasvir combo for these patients.
Exactly. And, connecting the mechanism of drug metabolism provides a really perfect bridge to the non-viral hepatidides.
Oh, absolutely. Because the liver isn't just an immune battleground. It's the body's primary chemical filtration plant.
Right. When investigating elevated aminotransferases, you must always evaluate for drug-induced liver injury or DLI and autoimmune processes.
So for DLI, acetaminophen toxicity is the absolute highest yield topic.
Without a doubt. It is the most common cause of acute liver failure in the United States and Europe.
And understanding the mechanism of injury here is totally paramount.
So normally acetaminophen is safely metabolized through glucuronidation and sulfation in the liver and then just excreted.
Right. However, in an overdose situation, those safe pathways become completely saturated.
And that's where the trouble starts. The excess acetaminophen is shunted to the cytochrome P450 system.
Specifically CYP2E1.
Exactly. And this pathway produces a highly reactive, toxic metabolite called NAPQI.
Under normal circumstances, the liver uses glutathione as a chemical sponge to neutralize NAPQI by donating a sulfhydryl group.
But in a massive overdose, those glutathione reserves are quickly depleted.
And once the glutathione is gone,
the unbound NAPQI binds covalently to the lipid bilayers and mitochondrial proteins of the hepatocytes,
resulting in devastating oxidative stress and massive central lobular necrosis.
Exactly, which is why the antidote, N-acetylcysteine, works precisely by replenishing those crucial glutathione stores.
So elegant.
Yeah.
Now, aside from acetaminophen, you also have to be able to recognize idiosyncratic drug reactions, which are not dose-dependent.
Right. Amoxicillin clavulanic acid is the most common antibiotic cause of DILI.
Typically presenting with a mixed hepatocellular and cholestatic injury pattern, right?
Yes. And another major culprit is isoniazid, a first-line tuberculosis medication.
Which can cause a severe acute hepatitis that really resembles a viral infection.
Exactly. Now, shifting from exogenous toxins to endogenous inflammation, we encounter autoimmune hepatitis, or AIH.
Right. Pathophysiologically, this is a progressive chronic inflammation driven by a loss of immune tolerance against the liver's own antigens.
And the demographic presentation is quite classic. You see a really strong female predominance with a bimodal age distribution.
So frequently presenting in young women under 30 or postmenopausal women over 60.
Right. And the histopathology of AIH features a super specific mechanism called interface hepatitis.
Oh, right. Instead of the inflammation staying confined within the portal tracts, the lymphocytes and plasma cells sort of spill out into the hepatic lobule.
Yes, actively eroding the limiting plate of hepatocytes.
And the damaged hepatocytes often cluster together in these formations known as rosettes, right?
Exactly, rosettes. Diagnostically, AIH is characterized by a marked hyperglobulinemia.
Specifically, highly elevated total serum IgG levels.
Right. We also look for specific autoantibodies. Type 1 AIH is associated with ANA, the anti-nuclear antibody, and ASMA, the anti-smooth muscle antibody.
And type 2 AIH, which generally affects pediatric patients, that's characterized by the anti-LKM1 antibody, right?
Spot on.
Okay, let's apply this to a differential diagnosis. Say a 19-year-old female patient presents with fatigue, jaundice, and chronically elevated aminotransferases.
A classic scenario. You absolutely have to differentiate between AIH and Wilson disease there.
Because both are major causes of chronic hepatitis in young populations.
Exactly. And the differentiation lies in understanding the underlying defect. Wilson disease is a genetic failure of copper transport.
So the key diagnostic lab is a dramatically low serum ceruloplasmin level.
Right. Ceruloplasmin is the protein that carries copper in the blood. Because the liver cannot attach the copper to the protein, the empty protein degrades.
Leaving low blood levels while free copper deposits in tissues.
Exactly, leading to things like Kaiser-Fleischer rings in the cornea.
Wow. And AIH, conversely, lacks those copper abnormalities and instead features the elevated IgG and positive autoantibodies.
Exactly. And once AIH is definitively diagnosed, the treatment relies on aggressively suppressing the overactive immune system
So induction of remission is achieved with high-dose glucocorticoids, usually prednisone.
to rapidly halt that inflammatory cascade.
And then once liver enzymes normalize, the steroids are slowly tapered while introducing a long-term steroid-sparing immunosuppressant, like azathioprine.
Perfect. So, wow, we have really covered the spectrum today.
We really have. From the resilient capsid of hepatitis A to the complex reading frames and reverse transcription of hepatitis B.
And the rapid mutations of hepatitis C, all the way to the specific toxic metabolites of acetaminophen and the autoantibodies of AIH.
It's a lot. And as you process all these mechanisms, consider the striking public health paradox we started with today.
Oh, right, the paradox.
We possess a highly effective, safe vaccine for hepatitis B. We can prevent it entirely. Yet, because the virus integrates its template into the host nucleus, we struggle to actually cure it. We can only suppress it.
Right. And in contrast, hepatitis C's hypervariable region makes creating a vaccine nearly impossible.
Yet, because its entire life cycle occurs in the cytoplasm and we fully understand its enzymatic machinery, we can completely cure it with a short course of targeted oral pills.
The biology directly dictates the global strategy. We are currently attempting to eradicate hepatitis C globally by 2030.
A disease with no vaccine.
Exactly. Relying entirely on rapid testing and highly effective treatment.
Treatment as prevention. Understanding the mechanisms behind these therapies and diseases is what will make you an exceptional clinician.
Absolutely.
Review your notes, trust your preparation, and remember the why behind the what. And this is the Digital Preceptor podcast. Wishing good luck on your exams.